Okay guys, here's the second part of the anticoagulation. So we've kind of covered our injectable anticoagulants, or for the most part. There's a couple other ones we'll touch base on here, but moving more into oral therapy, starting with our vitamin K antagonist, or also known as warfarin, brand name Coumadin, or other brand names. There's one called Jantavin that exists too, and I'll talk about the difference in that in a second. But for the most part, you have a drug that works by preventing the clotting factors that your body derives from vitamin K. So that's why these drugs, if you want to call them a group of drugs, are called vitamin K antagonists. But there's only one we use in human medicine, and that's warfarin. There are some other ones and other derivatives. You might hear some people refer to warfarin as rat poison. That's because there are rodent poisons that are kind of super powerful versions of warfarin that are similar in their mechanism. So that's where that kind of joke comes from. But this isn't rat poison, believe it or not. And my fun fact for the day is that vitamin K comes from the German word for coagulation, which is coagulation spelled with a K. So there you go. Well, there's a lot of clotting factors that are derived from vitamin K, including 2, 7, 9, and 10. Also, there's some other proteins called C and S, which I've got here, which are also derived from vitamin K. And these are actually act in your body as a natural anticoagulant, so it sort of helps balance the clotting system, and that system gets shut down. So the interesting thing about taking warfarin is that when you start taking it, your body shuts down production of these factors, but you see the biggest impact initially on these proteins C and S, which means that you actually go into a slightly hypercoagulable state because you've lost your natural anticoagulants and you still have several circulating standard clotting factors available. What happens is those patients are at higher risk for a clot. So when we talk about warfarin and efficacy, when we are doing our lab monitoring, we have to make sure that we're bridging the person with some sort of active anticoagulant during that initial phase, which can take up to 7 days, sometimes even longer. Warfarin's a tricky drug, and we'll get into some of this in a second here and some of the strategies, but it's not something that is really predictable. It's not easy to dose it, and it requires a lot of extra monitoring and a lot of extra patient visits. So we'll talk about some of the alternatives to warfarin, but once you kind of weigh the pros and the cons, you can see why a lot of people are moving away from warfarin now. Warfarin is hepatically metabolized. There's no renal adjustment needed for it, but it is highly prone to drug interactions, and the reason is because drug interactions just tend to affect it substantially. There are certain drugs that really affect warfarin, and it can mess up somebody's anticoagulation status pretty significantly if you don't monitor for it appropriately. And then you end up with somebody who's either way too anticoagulated or possibly under anticoagulated, and either one of those has risks associated with it. So by calling it a vitamin K antagonist, what we're talking about here is this enzyme called vitamin K oxide reductase, which is what warfarin is working on. There's two different enantiomers to warfarin. The S is the more active, which is why it's highlighted here. The R isn't quite as active. But what you get is a inhibition of this enzyme that's going to be helping to catalyze a reaction that converts clotting factors into their active form, or helps build more clotting factors. Here, there's an example of prothrombin or factor 2. So just as an example, you can see how that works. But again, we're inhibiting an enzyme that's catalyzing a reaction here. So warfarin is a once daily dose medication, but again, I said it was tricky. And what I mean by that is there's no standard dose to start somebody on warfarin. There's kind of a guesstimate you can make, but usually it's hard to see effects after a couple of days. You need it, well, after 1 day alone, you probably won't see any effects. After 2 days, you might start to see some changes in their INR. Now, there's some kind of general guidelines for dosing. Usually younger, heavier people are going to require larger doses. Older, smaller people are going to require lower doses, but that's not an absolute. What happens is that you have, if you dose somebody really high, let's say you have a young person, you dose them aggressively, maybe their body doesn't need that much, and then they end up getting over anticoagulated. So you do have to be really careful For the most part, a lot of people will start with a 5 milligram a day dose. That's a pretty safe bet. If you read some guidelines, they might say, we'll start with 10 milligrams a day for 2 days, and then put somebody and then decrease their dose after that. I think that's a bit aggressive, and I think what I've seen in practice and what's represented in a lot of literature is that warfarin's a difficult dose to load. So you can't get those effects immediately by giving somebody more warfarin. It just doesn't really work that way. What happens is the person will end up accumulating the warfarin, then their clotting factors are all tank, and then you're going to get an increased INR that spikes really quickly. So when we're dosing warfarin, we're targeting this thing called the INR, which is an international normalized ratio. And all that is a measurement of your body's time to clot. So it's looking at clotting time versus a person who's not on warfarin and how long that would be. So if I took anybody who's not on warfarin's blood and did an INR test, I'd probably get around 1. What we target for most warfarin patients is between 2 and 3. Maybe a little bit lower here for prophylaxis, down to 1.5. And then for mechanical valves, we can go up a little higher, 2.5 to 3.5. But generally, this 2 to 3 range is going to cover pretty much everybody. Everybody's going to fall in this 2.5, range for the most part. So that 2 to 3 range is an important one to remember. I'm not going to test you on INR monitoring, but just for your practice, that's a good thing to know, I think, because you're going to see tons of people on warfarin no matter where you practice. And it's good to know what the labs look like. So if you get an INR back and it comes back as 7, that should be a big red flag right away. As far as INRs go, again, this is a bit tricky. So when you're dosing somebody, for the most part, your goal is to get them to a stable dosing regimen, and that can be really variable depending on how you're approaching this. And I've got some more examples of this on the next slide, I think. But overall, the point is that you're checking INR and you're monitoring as frequently as you need to. Usually patients in a best case scenario will go down to monthly INR checks. Most people don't go down less than that. I've seen examples of people who have been really stable for a long period of time on a certain dosing regimen, and they end up getting maybe every other month checks or sometimes every 3 month checks. That's a little bit risky, I think, because warfarin can be affected by so many things. But ultimately, it is an option you could do. There's also home monitoring systems that are used for warfarin, for INR monitoring sometimes, and that can be okay for some patients. I think they've been proven to be not quite as accurate. But I think when it comes to INR testing, consistency is okay. So if you're using the machine regularly and you know that it's not quite as accurate as a normal one, but if you're using that machine, the same machine every time, then maybe it's okay. But sometimes we'll have people on a machine and they'll come in and get a lab draw, and it's quite different. Maybe by a difference between being in therapeutic range or not. So maybe their machine said they were 3.4. And they come in and then they're 3. So it's like, well, which one do we take? Usually the lab blood draw is going to be the more accurate one than a machine test. Okay, so I said don't load warfarin. So if you give somebody a huge dose of warfarin, what you're likely going to see is that INR is going to catch up later. So you aren't going to see very many immediate effects with that. But then 5 days down the road, you're probably going to see a pretty big spike, and it can be really difficult to play around with the dose, which is why it's best to be conservative and be steady with warfarin. That means try to avoid holding doses, try to avoid giving really big doses. Large shifts in dosing with warfarin are usually not compatible with good INR targeting. So you really want to be consistent, concise with this, and avoid what I like to call the ping pong effect, where I've seen this so many times when you have people who get a huge dose of warfarin, or somebody does a knee-jerk reaction. Maybe somebody's INR goes from 2 to 3 in a day. That's a pretty big jump. It's still within therapeutic range, but if you were 2 one day and you're 3 the next day, that's pretty substantial. And in that case, you can end up saying, oh, we need to hold a dose. You hold a dose, and then 2 days later, their INR is back to 1.2 because you held that dose. Now they don't have enough warfarin in their system. Warfarin's less about the day-to-day dosing, which can have an effect, but it's more about once you get people established, weekly averages. So what you want to push towards is a gradual dosing approach that gets them to a weekly average goal. And then you can kind of play around with that weekly dose. Maybe their weekly dose is 30 milligrams total a week. So then you're like, well, what are we looking at here? Do we need to increase it? So let's increase it by 5 milligrams. Let's not do all 5 milligrams of that on one day. Let's do 2.5 on Thursdays and 2.5 on Sundays or something like that, so that it's spread out. So that's a way you can approach warfarin dosing. I'm not going to get too much more into detail. There's a lot of people that spend their careers doing this, believe it or not. There's a lot of pharmacists that do this. We do this for every inpatient who comes into the hospital. We manage their warfarin, which is it's kind of a mundane task in some aspects, but it is important too. And there are clinics out there that specialize in this. There's a lot of nursing monitoring and nursing protocols set up with this. I'm not a huge fan of protocol-based warfarin dosing because I think it's not going to work for a lot of patients. If you're plugging warfarin changes into an algorithm, it's just so unpredictable that a lot of times the algorithm will kind of put its hands up and say, I don't know what to tell you. And we actually had a person on staff at Abbott for a long time who developed all these dosing protocol tools, and most of our pharmacists just gave up on them because they were either A, they didn't make sense, or B, the dosing protocol would just say, I don't know why this INR is increasing this high and I can't give you a recommendation. It's like, okay, thanks for the help there. But the point is it's very hard. Like with heparin, we talked about that being very protocolized. That's very different because with heparin, you eliminate it very consistently for most patients. Warfarin's just really inconsistent. And so you really have to be using clinical judgment, and a lot of times it's experience too. There's not a lot of there's guidelines and evidence and stuff out there for it, but for the most part, patients are going to respond very individually to warfarin. So it is something that does require a little bit of an art to it to dosing warfarin correctly. Food interactions. This is a big one. So vitamin K in your diet needs to be consistent. It's my biggest pet peeve about warfarin when I hear people say, avoid leafy green vegetables or avoid high vitamin K foods. That's an inappropriate recommendation to somebody. What you want to tell them to is keep their vitamin K consistent. So if you have somebody who doesn't eat a lot of vegetables as is, well, you probably don't have to worry about it too much, but let them know that if they decide to go out to dinner and order a huge spinach salad or something like that, or drink like a big green smoothie or something that they don't normally do, that can really affect your INR substantially. And you'd be it doesn't sound like much, but it does have a big impact if you consume a ton of vitamin K. So just make sure patients are consistent with what they're doing. If they're doing a spinach salad every day with dinner, that's fine to keep doing. Just make sure they don't skip it. Make sure they do it every day. Smokers tend to have an increased metabolism, so they might require higher warfarin dosing. And alcohol has some interesting effects. If you have chronic alcoholism, it might increase warfarin's metabolism. And the reason being is because your liver's sort of ramped up and used to processing a lot of alcohol. So a lot of those enzymes are working at their maximum capacity all the time, assuming you don't have liver failure. That would be a different story, because then you would just have you probably would have borderline low clotting factor production in general if your liver was failing. But for chronic alcoholics who still have a functioning liver, you're going to see increased warfarin metabolism. For people who binge, if you have a person who doesn't drink a lot and they binge drink, occasionally you can end up sort of shocking the liver, so it doesn't really produce enzymes as readily for maybe a day or two, or maybe it just not metabolizing the same process, and you can see a sudden decrease in warfarin metabolism, so you accumulate more. So those are some general trends you see with alcohol. I put these up here. Warfarin, no matter what brand, whether it's brand name Coumadin, brand name Jantoven, whether it's the generic versions, there's several manufacturers that make generic warfarin, you get a color scheme. So if you have somebody and they're like, oh, if they call you and they say, well, I took if they say they took an extra pill, you can say, well, do you remember if it was maybe they're getting a combination of 5 milligrams and 2.5 milligrams. You can say, well, did you take your 5s or your 2.5s? How much extra are we talking about here? And they're like, well, I don't remember. Well, do you remember what color it was? Oh, yeah, it was green. Well, okay, that's the 2.5s. Some of these look similar. So 2.5 to be honest, it's kind of difficult to tell the difference between some of these in real life, like 5s and 1s look pretty similar. But for the most part, they're like the different shades of blue and purple kind of all blend together. But for the most part, it is a standard color-coded system. And it leads me to some other discussions on warfarin. Warfarin dosing, again, is a little bit weird, and we're looking at weekly averages. So it's really common to see people on different doses, different days of the week. So they might be on 5 milligrams Monday, Wednesday, Friday, and 2.5 all the rest of the days. And we try and get them so that they could maybe take one type of pill, so maybe you don't have to fill multiple prescriptions for the person. So if you can do like multiples of 2.5, so they do 1 tablet or 2 tablets Monday, Wednesday, Friday, 1 tablet all the other days, versus taking a 5 and a 2.5 separate, because then they need 2 separate prescriptions. There's more likelihood for them messing that up, I think. So just keep that in mind, that there's a lot of different strengths available, but try and give them a prescription that's going to help them get to their goal strength per day with the minimum amount of different tablets that they have to take. You know, if you have a patient that's really with it, it's probably not a big deal, but just making sure you're giving them instructions and that you're looking at the prescribing options so that they're getting the most convenient combination possible. Okay, so with warfarin comes a reversal agent, which is vitamin K. So you can use this in a number of different capacities. I've seen people say in outpatient clinic situations who are on warfarin, if their INR comes back a little bit high, they might say, go eat a big green salad. Okay, well, that's not really like a predictable amount of vitamin K that they're getting. It could help, but it could also overdo it. Vitamin K lasts a long time, and the effects of it last quite a while too. So if you overdo vitamin K, it can be difficult and work against getting your INR back to therapeutic range. So if somebody's slightly outside of above therapeutic range and you want to bring their INR back down by giving them some vitamin K. So again, vitamin K is reversing warfarin's effect, so it's moving your INR down, decreasing it. You want to do it as controlled as possible, and so that's where just supplemental vitamin K can be really handy. So reversing warfarin, it takes about 6 hours to start working. So the one thing, I should say, not the one thing, but one thing to remember about warfarin or vitamin K is that it does not work quickly. So if you have somebody with an acute bleed or somebody who's been in a traumatic accident and they're on warfarin and they're bleeding out, vitamin K is not something that you're going to give for the acute phase. Now, certainly over time, if you want to hold their bleeding, you know, a day later, vitamin K is good to start. And a lot of times you'll give vitamin K, but it's not the high priority item. We'll talk about prothrombin complex concentrate in a few slides here, but that's the one that's more emergent. So, but anyway, vitamin K can be used for mild bleeding episodes. It can be used for pre-procedural things to reverse warfarin, but you are looking at about a whole day. So this is really important because I think people get impatient with medicine in general, and so when it comes to vitamin K, especially in like a hospital setting, it's like, oh, we gave a person a dose last night and their INR is still a little bit up. Let's double their dose. No, let's not. Let's wait another 12 hours and then figure it out. I've seen this happen so many times. A lot of times it's just inexperienced providers or providers who are getting impatient who are just slamming people with vitamin K. The problem is you tank somebody's warfarin so much that now they're way subtherapeutic and you still want them to have some anticoagulant effect. Then you have to bridge them with heparin or Lovenox in the meantime because their warfarin's not effective. It's going to take days for that vitamin K to wear off and days for that warfarin to get back in balance. And then it creates a nightmare for dosing for your pharmacists or your nurses or whoever's dosing it. Just a bad situation in general. So just like we want to be steady with our warfarin dosing in general and not make rapid changes, it's the same thing with vitamin K. You don't want to overdo it. Vitamin K does come as an IV and a PO form, so you can give orally. It's got good bioavailability. The only thing you're going to get an advantage with IV is that you're, first of all, bypassing the GI tract, so you're sure everything's getting into the patient, where if they're an alcoholic or if they are in the ICU and have poor oral intake or something, you might not be able to rely on the GI tract entirely, but for the most part, they're equivalent as far as bioavailability. What happens with PO is you have GI transit time, so IV effects are going to get to the liver faster, but you really don't get that much of an advantage. You might get a couple hours of a head start with IV therapy, but remember warfarin works roundabout. It's decreasing vitamin K, vitamin K's ability to synthesize, be a part of the clotting factor, synthesis pathways. So if you're working in a roundabout fashion that way, vitamin K also will take a while to synthesize new clotting factors. So that's the whole purpose of this, is if you overload somebody with vitamin K, start building new clotting factors, and then you can work against the effects that warfarin's having by reducing that ability. So the whole thing's roundabout. It's not direct. We aren't targeting receptors. We aren't doing anything like that. So it takes time. And that's probably the most important thing to remember, is that vitamin K reversal of warfarin is slow. We don't really do IM vitamin K intramuscular. It's painful, and there's really no purpose. If you need to get it in faster to somebody, do IV. Otherwise, PO is okay for the majority of patients. Dosing anywhere from 1.25 milligrams to 10 milligrams a day. I would stick with, again, lower doses and see how people respond. If somebody's INR is like 12, really high, you could hit them with a higher dose, but 10 milligrams I rarely see used, just because it's a really aggressive dose. 5 milligrams maybe for people who are substantially elevated, but if somebody could have an INR of 12 and be just fine. They have no evidence of bleeding. They just have a really high INR. You don't really need to treat them that aggressively. Just make sure you aren't doing anything to make them bleed. Put them in a hospital bed or an observation and give them some vitamin K. Probably orally would be fine, and let it trend down naturally, and just keep a monitor on that. I've seen people get just hammered with vitamin K, and then you're waiting days trying to get them back to their therapeutic range, and then you're risking a blood clot. You're spending more money on additional drugs that have to anticoagulate that patient. So again, I can't say enough about vitamin K and being careful with it. It's a good tool, but it's not like a perfect solution, because you're having to really titrate it carefully in patients, and you have to wait a long time for it to get its effects. So those are the big takeaways with vitamin K use. Okay, direct thrombin inhibitors. There's a few medications to talk about here. These two are IV products. So direct thrombin inhibitor binds to the site of factor 2. It inhibits fibrin formation and activation of some further factors. These two drugs are actually pretty good alternatives if somebody has HIT. So we talked about HIT with heparin. Argatroban and bivalirudin are both okay. They both can be given as IV boluses and infusions, just like heparin. They've got a lot of monitoring associated with them. There's some advantages maybe with using them. They're both pretty expensive, so as far as the grand scheme of things, we don't like them over heparin unless we have a good reason to do so. There's some evidence that during catheterization for like an N-STEMI patient, if they're going to the cath lab, they're usually anticoagulated with heparin, but there was a study that looked at bivalirudin that saw less bleeding and didn't really have any ultimate differences in endpoints, though, so didn't improve mortality or anything like that. So the question is that really all that relevant? But anyway, there's two options here, and both are direct targeted, but they both do require monitoring, just like heparin would. And it's usually a bit more advanced monitoring, so for example, where we have nurses monitoring heparin at our hospital, pharmacists would specifically monitor these two drugs. The oral direct thrombin inhibitor is called dabigatran or however you want to say it. It's Pradaxa, and it's the only oral direct thrombin inhibitor on the market. It's approved for use in atrial fibrillation. I say this only, but I think this is wrong. I've got another slide that shows some indications. Just ignore that. I'm pretty sure it's got several other indications now. Build has required no monitoring, no CYP interactions. So this drug came out, it was the first basically warfarin equivalent drug that came onto the market, and it came on a few years ago. And so everyone was kind of going nuts over it, because people, while we've used warfarin for many years and we're somewhat comfortable with it, no one really likes warfarin. All the drug interactions, all the food interactions, all the monitoring and inconveniencing patients, it's just kind of a pain in every aspect. I don't think there's many good things about warfarin. Now you have a new drug that comes on the market that says, hey, we don't have any drug interactions. This is dosed twice daily. It's renally eliminated. It's got predictable kinetics. It's a direct targeted anticoagulant, so it's going directly to thrombin. It's not inhibiting clotting factors through a roundabout mechanism. And what you do get is again a predictable response and a predictable elimination pathway, which means technically you don't have to monitor for this drug at all. Now, some people have monitor it anyway. They've made either in-house monitoring tests for this, or they use kind of extrapolate by measuring activity levels of certain factors. You can measure activity levels of like factor 10 and factor 2, and some other things that might give you a hint. And I've got another slide that shows some of those options, but for the most part, there's no monitoring associated with this. So you have a drug that has no interactions or anything, but does it. Interestingly enough, they think that this drug is actually pretty affected by something called P-glycoprotein interactions. P-glycoprotein transporters are used in the GI tract, and there's actually a number of things that drugs that use them, so they help pull them out of the GI tract, and it's thought that certain drugs might inhibit this process, and if that does that, you can have a situation where your body's not basically absorbing any of it. And we don't have dosing fleshed out for that or understand that quite as much as far as like the general clinical impact of that compared to CYP interactions, but you have it's just something to consider. So we'll come back to that in a couple slides here when I talk more about comparing like all the new oral anticoagulants. Okay, factor 10A inhibitors, there's a couple of these here. Fondaparinux is a subcutaneous injection. It's very similar to our low molecular heparins like enoxaparin. It's a useful bridging agent, especially if you have HIT risk. It's once daily dose. That's about all I'm going to say about it. Rivaroxaban or Xarelto was the first factor 10A inhibitor orally to come to the market. And it has currently the most FDA-approved indications for use. It started in post-op hip knee replacement, and then now it's got atrial fibrillation, VTE. It's got several other things. One thing about dabigatran or Pradaxa is that you have some pretty significant post-marketing bleeding risk associated with it that's been coming out. Rivaroxaban seems to have lower risk overall, and I'll show you some comparisons here again in a few slides. It is a major CYP3A4 substrate, and maybe we will see an increased role. You can tell I haven't updated these as much as I should. It has a huge increased role now. Rivaroxaban is probably one of the most popular anticoagulants on the market right now, in addition to the one on the next slide I'm going to talk about in a second. But this one has major CYP3A4 substrate, so you do get P-glycoprotein as well, just like dabigatran. So you do get prone to drug interactions. It does require renal dosing and adjustment, so that's something to consider too. Apixaban is the other new one that is really popular as well. It's Eliquis. Approved, shows good evidence for atrial fibrillation. It's the least renally eliminated agent, and it's been actually studied in a subset of patients with renal failure, where rivaroxaban and dabigatran have not really had as profound evidence in there. And based on our current evidence and what we're looking at, it probably has the best safety profile, meaning the lowest overall bleeding risk out of all the new oral anticoagulants. There's some other factor 10A inhibitors coming to the market. There's one, I think, already called edoxaban. I'm not sure the brand name of that. I think I've got it on another slide here. But there's other ones in the works too. But the thing about it is, unless they can prove that they're substantially different, you have two drugs right now, rivaroxaban and apixaban, that are starting to get approved by insurances. So insurances are putting them as preferred formulary agents. So they're paying for these medications more and more frequently as they get more and more popular. And it's going to be hard for any other drugs to catch up to these two at this point. These are the two popular ones, and the rest of them are pretty much Me Too drugs. And again, unless they can prove that through some study that maybe they work better in certain patient populations, or they have better evidence for bleeding rates, you probably aren't going to see a lot of use outside of these two drugs. Okay, I do want to spend some more time talking about these medications because they're so relevant right now, and we're really starting to see them take off in a big way. And I've got a number of comparison slides coming up, and I'm not going to test you on this information, but I would like you to know the differences in the drugs. So, like, I certainly want you to know them and want you to know their mechanisms. Like, if I talk about rivaroxaban or apixaban on a test, you should certainly know what those are. I'm not going to test you on all the clinical evidence I'm going to show you here, or on on some of the nuanced stuff. So I'll let you know on a summary slide at the end sort of what I want you to know. But just know that I've got several slides coming up, and it's mostly just for your information type things. So what are these drugs called as a group? All the new oral anticoagulants have been called a number of things. So they've been called NOACs, which stands for new oral anticoagulant. They've been called DOACs, which stands for direct acting oral anticoagulant. They've been called TSOACs, which is target specific oral anticoagulants. Any one is fine. I think I hear NOAC or DOAC the most because no one likes saying TSOAC. It's a little bit less doesn't roll off the tongue quite as easily. They aren't better than warfarin. That's a important point to make. They've all been studied and proven to be non-inferior to warfarin, but that's the thing. They don't need to be better than warfarin. Warfarin we've known for years as a gold standard for anticoagulation, and so these drugs don't have to be any better. Different studies have shown some possible improvements over warfarin. So I just want to point out that some of the studies are a little bit interesting, where they'll compare the warfarin arm to people who have been controlled on warfarin and had INRs within target range at least 60% of the time. That's what they consider to be good. If you look at a really good warfarin clinic that knows what they're doing, most of those patients will be in range 90+% of the time. So that was a big controversy with some of these studies. It's like, well, you're comparing it to people who generally 40% of the time they aren't even within the right therapeutic range. So how can we really take that as that modeled warfarin therapy? And they would argue that yes, that is realistic, because not all sites have 90% of goals. Some sites might be terrible at getting their patients in goals. So we'd say, so yeah, 60 based on the literature is an appropriate target. So there's, again, it's like, are we really comparing apples to apples here? But for the most part, probably, yeah, we are. I think we are. I think there's some good evidence for these drugs that makes them work. But there is that controversy that, warfarin could be superior if they actually looked at, the best of the monitoring. But it's true that you aren't going to get that everywhere you go. These drugs don't have any dietary restrictions. There's no vitamin K interaction. That's a big deal for patients. So who is the ideal candidate for this if you're comparing head-to-head? Well, a non-elderly patient would be probably ideal. And remember, I'm talking about ideal here. I'm not talking about absolute contraindications or anything like that. Elderly patients can certainly be on these drugs too. But a non-elderly, good kidney function, relatively normal weight, somebody maybe with poor access to lab facilities who can't get INRs done regularly would be another ideal patient who would maybe meet some of this criteria, and predictable kinetics. So I've heard it argued, people are like, well, maybe somebody who's non-adherent should be good with this because they are maybe they aren't coming in for their lab draws regularly. Well, the thing to remember about that is if you're non-adherent with your lab draws, or you miss doses of your warfarin, warfarin's actually probably the best option for you, because you can miss a dose of warfarin and actually be okay. You can kind of make that up throughout the rest of the week. Remember, we talk about weekly averages. Yeah, it's not going to be ideal, and your INR is probably going to take a hit, but overall, it's got a bit of a buffer. If you miss one dose of one of these medications, they usually have about a 10 to 12 hour half-life. That could be the risk. You could be risking a potential clot at that point, because if the drug's out of your system after 12 hours, that's going to cause you're going to be not anticoagulated anymore, and then of course you could have a clot. So that's something that is just keep in the back of your head, that these medications actually do better in patients who are compliant. You do have to take them regularly. It is really important not to miss doses. Missed doses can be catastrophic. No monitoring. So again, you don't have to come in monthly for your INRs. You actually don't have to come in at all. And then cost comparison is the other big sticking point. And I think this is fading away a little bit now that insurance companies are paying for these. But when these drugs first came out, no one was paying for them, and everyone's like, warfarin, even with monitoring, is quite a bit cheaper. So warfarin, the drug, costs nothing basically. Monitoring, let's say with lab monitoring coming in once a month, you're looking at $100 a month. If you consider that a new oral anticoagulant probably costs about $300 a month, of course there's not cost savings there. You're paying more money for the new drug even without the lab draws, but you take some intangibles into consideration. You don't have to worry about your diet. You don't have to drive yourself to the clinic. You don't have to waste time sitting, waiting for a clinic, waiting for a blood draw, going over the information with somebody every single month. That's going to that's going to be time that is, possibly, again, an intangible value there, depending on the person. I've talked to a lot of people who are friends or family members who've had clots or are on an anticoagulation. They're like, oh, I have a DVT. I have to go on an anticoagulant. What would you recommend? I would take a target-specific oral anticoagulant over warfarin 100% of the time for me personally. But again, it depends on the situation. So what other things do you have going on? And we'll talk about some of those things here in a second here. Okay, approved indications. So we have, again, pretty much all of these have had enough evidence and gone through the FDA approval process enough where they've got pretty much all for the same indication. So you have non-valvular AFib, DVT-PE treatment, and DVT-PE secondary prevention as the major ones. And here's just all the dosing for it. You can see it's a little bit confusing, whereas like with Pradaxa, it's all the same. Rivaroxaban has different dosing, and apixaban also has some different dosing too. And edoxaban's the same. So it's like, why are some different and some the same? It's like, well, some of these you might not need quite as much. I think the idea with the DVT treatment is that you load somebody up, you give them a higher dose over a certain period of time, and then they can go to the standard dosing after that. I don't know. That's the way they studied them in the trials, so that's the way they approved them. Okay, Tmax, these drugs are going to start very quickly. We talked about injectable enoxaparin, and you might be thinking, well, okay, so that had like a 4-hour Tmax, right? So what about these drugs? Can these be used to bridge somebody to warfarin? They could, but the better question is, can they just be used altogether? So you can, basically, you don't have to bridge somebody at all with these medications. You just start them on them. So let's say somebody comes into your urgent care clinic or emergency department, they get diagnosed with a DVT. You want to put them on rivaroxaban. You start them on rivaroxaban that day and you send them home. You don't bridge them. You don't monitor them. There's really nothing involved with that as long as they meet criteria. So that's the convenience aspect about it. And it's also been sort of probably these drugs' biggest foil too, is that there's just the comfort level with them, I think, is getting better. But at first people are like, wait, I'm just sending somebody home on an anticoagulant and I'm not monitoring them. What happens if they bleed out? Well, these drugs, again, have predictable kinetics. They shouldn't cause bleeding if you dose them correctly. So again, you don't need to bridge them. Initial IV anticoagulation. So interestingly enough, some of these drugs were studied with a bridging therapy for some reason. So for example, dabigatran said if you had a DVT or PDE, you actually should have some sort of IV, like do them on IV heparin for 5 to 10 days and then convert them. And edoxaban was actually studied similar. Rivaroxaban and apixaban both studied just using that drug alone and nothing else, and found it to be non-inferior to the alternative of doing heparin or doing low molecular weight heparin plus warfarin. So that's, again, why these two drugs are so popular, is because you can just start them on it, send them home, and that's all you really need to do. And it makes sense. I don't understand why dabigatran didn't study it that way, because their drug's got a 1 to 3 hour half-life. It works quickly. It's target specific. It's going to target exactly the clotting factors you need to do. And why they set themselves up for failure by bridging with IV therapy for no reason, I have no idea. Or maybe they trialed it the other way and just it wasn't working, so then they did their bigger trial like this. I don't know. Half-life, you can see, is all pretty much the same, which is interesting because if we go back to this other slide here, you can see rivaroxaban is dosed once daily. Apixaban is dosed twice daily. I'm going to focus mostly on these two, by the way, because they're the two most important ones from the grand scheme of things in clinical medicine right now. But you can see their half-life is actually really similar. Rivaroxaban's a little shorter, which is interesting because it's the once daily one. So why is it dosed once daily? I don't know. That's the way they decided to do it, and it seemed to work in the studies. Again, I don't have a better explanation than that. You can monitor these using an anti-10A level. It has to be calibrated for the specific drug. So, an in-house lab would have to basically build and calibrate their own machines to make sure that they could not build their own machines, but they'd have to use whatever factor 10A assay they have and make sure it's calibrated appropriately each time they would run it if they're switching between, different drugs. So that's a bit of a pain. In both drugs, everything requires a renal adjustment except for warfarin. So one thing to remember about warfarin right off the bat is that these drugs are not good for people with severe renal failure. So the new drugs don't qualify. So if you have somebody on dialysis or end-stage CKD, they're always going to be on warfarin. That's one patient population. You're never going to have them on a new oral anticoagulant. Okay, more comparisons. There's some pearls here. I'm not going to go through a lot of this. Apixaban has a category B in pregnancy. It hasn't really been studied in pregnancy yet, but this could be a big game changer for pregnant venous thromboembolism, which is a common condition for pregnant patients. Reversal. I'll talk about these more specifically in a second here, but you have a new reversal agent that was approved for dabigatran, and then I thought I updated this, but must not have been the most recent one on here. Anyway, rivaroxaban, apixaban, and edoxaban all have this new drug that's coming out to be used for it, but it was supposed to come out last year. It hasn't yet. It's supposed to come out this year still. It probably won't. It's in phase. It's gone through phase 3 clinical trials, and now the FDA actually asked it to do more testing. And I'll talk about these specifically, so I'm going to skip that for now and kind of keep going. Spending enough time on this already. I'm not going to go through this specifically. You can look at it if you want. These are all the studies that they looked at, and it shows you the decreased bleeding risk compared to warfarin. Overall, what you're seeing is lower bleeding risk, and that's all I'm going to leave it at. Equal bleeding risk or lower bleeding risk. There's rarely anything that showed a higher bleeding risk compared to warfarin, especially if we're looking at our apixabans and rivaroxabans. So rivaroxaban did have a bit higher GI bleeding, interestingly enough here. I think it was minor GI bleeding, though. Outcomes, non-inferior, or and ultimately overall for major bleeding, what they qualified as major, you had lower rates for pretty much every study. This is versus enoxaparin vitamin K antagonist is what this means. So it's a combination. So you're looking at bridging somebody to warfarin using enoxaparin versus just these drugs alone. Renal consideration. Again, all are renally dosed, and here's how they all dose themselves. I'm not going to test you on this. I don't care you know this, other than to remember that warfarin is our preferred drug in advanced renal failure. Pretty much once your creatinine clearance drops below 15, you don't qualify for these medications. And you really don't qualify for a lot of them. Well, some of them will cut you off at 30 to 15 being maybe a no man's land type thing. Hepatic considerations, I'm going to skip this. I don't care you know about that. You can read that on your own if you're interested. And age is sort of interesting. I think the biggest one with age is apixaban. They showed that exposure to the drug increases about 30% for patients over 60 years. And so they're the only drug that's actually had age incorporated into their dose adjustments. And I'm going to continue to wait because they are also the only drug that had low weight incorporated into dose adjustment. So apixaban's sort of an interesting drug where, if you look at most drug monographs, it'll say if your renal function is this, dose this way. Apixaban says a couple things. It'll say, okay, if your weight is less than I can't remember, they didn't cut it off at 50 kilos. I don't remember what their cutoff was. But I think it was like 60 kilos or something. They put it a little higher than what the low end was. But anyway, they said if your weight is lower than a certain amount, if your age is above a certain amount, and if your renal function meets certain criteria, 2 out of 3 of those would mean that you'd empirically dose reduce. But if your renal function is poor, but still okay enough to be on the drug, and your weight and age are okay per our guidelines, you don't have to dose reduce. So they want you to meet 2 of 3 criteria because they think that those things increase exposure to the drug enough. So basically it's increasing the amount that's circulating in your body that you would need to empirically dose reduce. So again, it's sort of an interesting dosing strategy. I've never seen any other drug do that. So just know if you're starting somebody on apixaban, it does have those criteria: the weight, the age, and the renal function. So that's probably the most important thing to remember about all this stuff related to dosing, is that all these new ones are dosed based on renal function, but apixaban has those different criteria for weight and age. Drug interactions, again, some of this stuff I'm just going to skip through here. Okay, so ultimately we talked about a number of things over the last few slides. I hope that gave you a little bit of a snapshot into the new oral anticoagulants. Again, I'm not going to test you on a lot of that information. What I would like you to remember is the renal function thing, and that I just talked about, and just knowing that apixaban has those different indications too. So or not indications, sorry, different criteria for dose reduction. So pros and cons, ultimately, what we're looking at here. Advantages: no INR checks, no diet restrictions, less severe bleeding, fewer drug interactions, easier pre-op management, because you can stop the medication the day before and then the person's not anticoagulated. You have to stop warfarin 5 days in advance. If they're INR tanks, you have to bridge them with enoxaparin and then stop that the day before surgery. It's a pain. These drugs are a lot cleaner. You don't have to bridge with heparin with these either. Disadvantages: they're more expensive. Not approved for all indications. You don't have valvular AFib approved. You don't have any studies in renal failure. Compliance is a problem. You miss a dose, that's a big deal potentially. Interestingly enough, studies have showed that patients discontinue these drugs at a higher rate compared to warfarin. No one knows exactly why. They don't have a lot of side effects other than bleeding, so people aren't really sure about that. Dose adjustments needed for renal dysfunction, and there's no data for patients in dialysis, like I just said. I think as these drugs get more commonly used, we're going to see more data come out to address some of these things, specifically the renal function areas. But overall, these drugs are taking off pretty frequently as far as their use goes. We're seeing a lot more of this than we did a few years ago. All right, a couple more slides. Reversal. This is the medication that reverses dabigatran, and all I want you to know about this is I'm not going to test you on this medication, other than just to know that there is a reversal for dabigatran. And I just want to point out that they studied this in, I think, 90 patients or something. I don't know. It was a really small. Sorry, I should really update this. This is currently approved, which it says up here at the big star. But the point is that they did this in a really small study and found that it reverses dabigatran fine, and they approved it. Okay, cool. Adenexate alpha, which is the one that reverses factor Xa inhibitors, and both of these drugs work pretty much the same way. They basically have, well, let's go back here for a second. You have a monoclonal antibody here that binds to dabigatran much more so than thrombin. So it's competing with dabigatran for thrombin, binds it up, therefore it can't be used, basically neutralizes its activity. This one is a modified recombinant factor Xa derivative, and the factor 10, so it's pretty much the same thing. It's basically making this different looking factor Xa type molecule in the body, and the inhibitors are going to bind to that more so than they would the endogenous factor Xa, and again, it basically neutralizes it. This study I said earlier is still in kind of advanced phase 3 clinical trials. This drug should be approved soon. I'm not sure what's taking it so long. It kind of blows my mind that the FDA allowed the approval of the other drug with such a small study amount, and then this one they're making them go back and get more data, which is good because we probably want to know how to use this more so. The other thing could be is that with these drugs, these are the popular ones. The factor Xa inhibitors are the big ones, and those are going to be the ones going forward are going to be the major drugs that we're going to see used for anticoagulation. So that's probably why the FDA is maybe scrutinizing it more, but it doesn't really give the excuse of why they approved this drug, which is also called Praxbind, with very little evidence for it. So anyway, hopefully we'll see this one come out. I have physicians ask me all the time. They're like, hey, is that drug out yet? I want to use it in a patient. I'm like, no, it's not out. And even if it was, it's going to be super expensive, and you aren't just going to get to use it whenever you feel like it. It's going to have to be, really severe life-threatening bleed. These are probably going to be in the $10,000 to $20,000 a dose neighborhood is what I'd imagine, so definitely expensive. Other reversal agents, you can reverse INRs with fresh frozen plasma, but you usually can't get below 1.8, so it's not great, and you need a lot of volume. It's not an ideal situation. The drug we like to use to reverse warfarin acutely is prothrombin complex concentrate, which basically gives your body a bunch of clotting factors all at once. And some of the new agents have shown okay reversal. So currently it is recommended for most new agents that we reverse them with PCC, but the evidence isn't as robust as warfarin. It's actually pretty cool to watch this drug work. You give somebody an infusion of PCC, you measure that. I had a patient, I don't know, a while ago, they had an INR of like 9, significant GI bleed, wanted to go to surgery right away. So reverse them with PCC. Their INR went from 9 to 1 in 20 minutes. And it probably went faster than that. The point is that this drug works essentially instantaneously. And your risk is that, yeah, you could maybe have a clot associated with that, but it's pretty well tolerated, and usually we're seeing really good results with this. So any severe bleeding, this drug's a drug of choice, specifically for warfarin. And remember, vitamin K doesn't work fast. So a lot of times what we'll do is we'll give PCC, then we'll give a big bolus of vitamin K for a major bleed, IV, and that ideally, once the PCC wears off, the vitamin K is still going, so you have some sustained anticoagulation effects that way. So if you see both of them done at the same time, don't be like, oh, you can't use vitamin K, it's not going to work quickly, because you're right, the PCC is the important one here, but we want to make sure that vitamin K is on board too, because that'll sustain your ability to produce extra clotting factors over the next couple of days. Thrombolytics, we'll talk about these during ACS quickly. We'll talk about them during stroke. And if you want to pause and just think about some of the things I've talked about and think about, okay, if you had a new patient with a DVT or PE, how would you treat them? You can do that now. And I'm going to go through sort of a mock case. So we've talked about a number of things. So let's say we've got a patient who is comes into your emergency department. You don't really know much about their history. They claim they don't really have much of a history. You do some labs on them. They're complaining of pain in their leg. Ultrasound them, you diagnose a DVT. So what do you do? Well, the question is, are they okay for outpatient therapy or not? And a PE is the same way. We can actually treat a lot of mild PEs outpatient as well now. Those used to always warrant a hospital admission, not so much anymore. There's some good evidence that shows that you can manage PE actually pretty effectively as an outpatient for, obviously, people who are stable. So that's the first question, is somebody going to come in or not? If somebody comes into the hospital, heparin's the way to go. We always want to start with heparin because it's cheap, it's effective, it's easy to titrate, easy to manage. Eventually, that person's not going to stay in the hospital forever, hopefully, so you're going to discharge them and you want them on something oral. So your first thought is a couple of things. Ideally, you probably want them on a new oral anticoagulant because it's convenient for most patients compared to warfarin. So the question is, can you do that? First things first, can they afford it? If they can't afford it, they aren't going to take it. So make sure they can pay for it. What you can do is call your pharmacy that you're going to prescribe the medication to and ask them to run a test claim. They can enter the patient just like they're running a real claim and see if they pay for it or not. It can be really challenging to figure stuff out and what's covered by insurance companies unless you actually have the pharmacy process it. Pharmacy comes back and says, yeah, you know, they won't pay for rivaroxaban, but they cover apixaban. And you're like, okay, great, I'll prescribe them apixaban. But before you do that, what do you need to think about? You need to think about renal function, age, and weight. So those three things. If they meet all the correct criteria with that, you could prescribe it. If they don't, that would be a no-go for you. So ultimately, you want to have the knowledge to be able to say when a patient could or could not take a specific anticoagulant. Warfarin really has no contraindications. So remember that it's the fail-safe, it's the backup. But now, current medicine, we're generally trying to do the new oral anticoagulants as much as possible. The other thing you could do is what we did for years and years is discharge somebody on enoxaparin and give them warfarin too, have them follow up with their clinic, get their INRs going. But now that's fallen by the wayside because we're just giving people rivaroxaban and apixaban right away, and then they're discharging them that way. So again, you have no contraindications to warfarin, so there are patients that are going to meet that criteria. And interestingly enough, like in our emergency department, and I think in Minnesota in general, from what I've seen as prescribing habits, people have pretty well embraced these new oral anticoagulants. As an example, my dad has a genetic clotting disorder, which I actually have too, but it's factor V Leiden, which puts him at risk for DVTs and PEs. Anyway, he's had a couple PEs over like the last 10 years, and the most recent one he went to a facility, he's in Colorado, and he went to a Kaiser Permanente facility, and they refused to prescribe factor Xa inhibitors, which I think is just awful, but they don't, and they would only do warfarin or Pradaxa. Pradaxa has increased bleeding risk, and so it's just, you will run into these different practice things where they say, nope, we aren't going to do this, and the reason is because they're scared of the bleed risk associated with it. They're like, there's not a good reversal agent for it. Well, the bleeding risk is a lot lower, though, generally speaking, when you compare it directly to warfarin. So you've got a catch-22 here, right? Once that reversal agent comes out, I think these drugs are going to, hopefully whoever's holding out on these is going to take off, because really for patient satisfaction and patient convenience, the new drugs are much better. There's just no argument there. Now, I do get the risk of bleeding and the fear of not having a reversal agent, but that's, you're being afraid of that 1% incidence and ignoring the other 99% benefit you're getting from it. So that's my opinion on it. But if you want to go back through some of the drugs and think about different strategies you could do for pulmonary embolism, you can certainly do that.